We have only 1 minute left. So, is my sound clear?
Yeah, very much.
Okay.
How about mine? Can you hear me well?
Yeah, of course. Yeah, sure. Dr. Shadman, can you speak by phone? Have you got any microphone?
Yeah, well, I can talk, but I was muted and the host wouldn't let me unmute myself. But sounds
because
like
because during the presentation, I will ask you to talk a little bit about the program.
Yeah, I would be happy to. Right now, it sounds like the problem is fixed now, but I couldn't. Anyway, so we're good now.
Okay. I think we've got to start the program. Hello, everybody, and welcome to our webinar in hematology entitled as How I Treat Hematologic Malignancies. I am Farid Kosari, hematopathologist from Tehran University of Medical Sciences. So delighted to moderate the first lecture named as How I Diagnose Acute Leukemia. I personally think, despite many disadvantages of COVID-19, it's a good opportunity in, let's say, quote unquote, Corona time that many national and international webinars have been established. And through that, scientific connections and collaboration organized. Accordingly, we have witnessed the reinforcement of interconnection between Tehran University of Medical Sciences and several scientific centers. In view of that, it's my pleasure to invite Dr. Maziar Shadman, Associate Professor of Medical Oncology, University of Michigan, as the main coordinator of this program, to have a short talk about this lecture series. Dr. Shadman.
Thank you very much, Dr. Kosari. I'm actually at the University of Washington in Seattle, but I appreciate the introduction. I won't take much time from today's talk. I just wanted to first thank and congratulate Tehran University and the Appraise to Race team for organizing such an important educational series. Of course, Dr. Yaghmai should really get all the credit for all the hard work that she's doing behind the scenes with her team. And again, we're very excited to have this series started today. The idea of having a virtual educational program really came up almost a year ago, and I happily agreed to serve as the contact person in the US. And it has been my pleasure to work with my colleagues in different academic centers who will be speaking in the series in the upcoming months. Really, with the explosion of information in the field of oncology and in heme malignancies specifically, it's almost impossible. It's very challenging to remain updated on novel diagnostic and therapeutic approaches. And really, the goal of this series is to have a comprehensive, evidence-based, and yet concise review of different topics. And our speakers have actually specifically structured their talks to achieve these goals. And I really thank them, and I really appreciate it. Every single person that I approached in the past few months really accepted this invitation with open arms, virtually, given the physical distancing rules. And we have an excellent lineup of speakers who you will know in the upcoming weeks and months. With that, I won't take more time, and I'll see you shortly in the next few weeks with the clinical therapeutic lectures. Dr. Kosari.
Thank you very much, Dr. Shadman, for your presentation. I want to just recap that our first lecture topic is How I Diagnose Acute Leukemia, which is going to be presented by Dr. Sanam Loghavi. Dr. Loghavi is Assistant Professor of Pathology in Department of Hematopathology, University of Texas, MD Anderson Cancer Center, Houston. She received her MD degree from Islamic Azad University, Tehran branch, and then completed her residency in APCP as Cedars Sinai Medical Center, Los Angeles, followed by fellowship training in surgical pathology, hematopathology, molecular pathology, everything pathology and at MD Anderson. Although I personally believe that how I diagnose acute leukemia is really a huge or general topic for hematopathologists as a specialist to cover in 1 hour, but I also believe that Dr. Loghavi can make it. So with that, Dr. Loghavi, I'm going to hand you control as presenter, and we'll see if you can see your slides.
Yeah, absolutely. Let me share my screen. Let me screenshot this first. Okay, let's see. Are you able to see my screen now?
Yeah.
And you're seeing the presentation?
Yeah, well, we can see your screen, and there we go. Take it away.
But are you seeing the actual slide that says how I diagnose acute leukemia? Because I can't see my own screen anymore.
So I can see your screen.
Yeah, you can see it, right?
Yeah. Can you see right now?
Well, it's okay. I can see my own, but I don't see what you're seeing. So
I think it's the first slide, how I diagnose acute leukemia, acute myeloid leukemia.
Yeah, thank you so much.
Yeah.
All right, so yes. Well, first of all, I want to thank you all for your very kind invitation, specifically you, Dr. Kosari, Dr. Shadman, and Dr. Yaghmai, who've done an outstanding job in organizing this series. And I'm really delighted. I didn't know that I was the first to present in this series, so it's truly an honor and a pleasure. Thank you so much for having me. As Dr. Kosari said, I feel like, covering how I diagnose acute leukemia in an hour would be an impossible task. So I took it upon myself to, make the lecture a little bit more specific and talk about acute myeloid leukemia. That way you'll have, you'll have an excuse to invite me back again to cover the other kinds of leukemias in case, hopefully if you like this lecture. All right, so I have no relevant conflicts of interest to disclose. And I'll tell you a little bit about my background. So as Dr. Kosari said, I did my, I got my MD in Tehran at Azad University. This is the latest picture that I found online. It didn't look like this when I was there. It looked much smaller and much simpler. And Dr. Shakur was my first pathology attending at Azad University. And then I moved to the US, did my residency at Cedars-Sinai, and then I did a bunch of fellowships. They made me do a lot of fellowships before they actually gave me a job. But they finally gave me a job, and so I've been here at MD Anderson since 2015 on staff. I do mostly, we're very subspecialized here because it is a cancer center. So I focus on myeloid malignancies in general, and then a lot of molecular classification, and then measurable residual disease and minimal residual disease detection. So that's my area of expertise and interest. This is a picture of our campus here at MD Anderson, and we are located here south of Texas in Houston, pretty much close to the Gulf of Mexico. All right, so the outline of today's talk is, our diagnostic approach to acute myeloid leukemia. How do we diagnose acute myeloid leukemia at MD Anderson? And then, a lot of the talk I'll focus on speaking about surveillance in acute myeloid leukemia and measurable residual disease detection. And then we'll talk a little bit about clonal hematopoiesis and how it pertains to MRD testing. What does it mean for us in this day and age when we try and diagnose these patients and follow them up? And then what are the future directions of measurable residual assessment, measurable residual disease assessment for patients with acute myeloid leukemia? So if you look at this year's statistics for acute myeloid leukemia, there were about 19,940 cases of new AML diagnosed in 2020 in the United States. Fortunately, it's a very uncommon form of cancer. It's about 1.1% of all newly diagnosed cancers. However, as you can see, the survival rate, the 5-year survival rate is only about 29%, which is really pretty dismal still, even with all the advances that we've made in the field. So there's still a lot of work to be done for patients with acute myeloid leukemia. To give you an idea about our, I think we're one of the largest leukemia centers in the country. We see about, you can see it ranges, AML, these are new cases of AML, ranges somewhere from 500. This is the latest, as you would imagine, in 2020, our numbers were a little bit down because of, the COVID crisis. But this is, the first half of 2019, and we saw about 360 cases, which is, about 3% of all US patients. So it's a good representation of these patients. In terms of our numbers in hematopathology, we see somewhere between 40 to 60 bone marrows a day. So it's a very, very busy hempath practice. We have about 13,000 average bone marrows yearly. And then as a result of that, we're doing a lot of flow cytometry. Specifically, we did about 2,800 cases of AML MRD by flow in 2018. So this is a little bit older, but gives you an idea of our numbers. So if you look at the 2016 classification of acute myeloid leukemia in the WHO series, this list has just grown pretty much exponentially in the recent years. We went from the FAB classification to now a classification that is essentially based on genetics. In order to be able to accurately diagnose an acute myeloid leukemia and give a subclassification in order to inform treatment, nowadays, you really need to be able to genetically characterize these lesions. So that's what we do. Essentially, our diagnosis revolves around morphologic evaluation. We immunophenotypically characterize every single case. The majority of our cases are done by flow because fortunately I know it's a little bit different in Europe. I don't know how it is in Iran. But here in the Department of Pathology, we get the bone marrow aspirates and the bone marrow cores together. So the practice is not dissociated. We have the advantage of seeing the actual core biopsy and actually being able to characterize the aspirate as well. And then cytogenetics, which encompasses karyotype and FISH. Nowadays, every single case gets a next generation sequencing panel to characterize somatic mutations. So why is that? Why is genomic classification so important? It's because it's prognostically important. If you look at the probability of survival in patients with acute leukemia, it's very, very variable, where you have, the translocation associated leukemias like acute promyelocytic leukemia or core binding factor leukemias that have relatively better prognosis. Whereas those with inversion 3 or KMT2A or MLL fusions and translocation 6/9 have very poor prognosis. And then also somatic mutations play an important role, specifically in the intermediate risk category with the diploid karyotypes. And these are all now built into the relevant prognostic classification systems. So right now, what we're using in the US is the ELN classification system. And you can see that the risk categories of favorable, intermediate, and adverse are essentially based on either chromosomal alterations or mutations, somatic mutations. So the most important somatic mutations that we look for, we look for a large number of mutations, but the ones that are prognostically relevant and or have treatment implications are NPM1, FLT3, CEBPA, and then RUNX1, ASXL1, and TP53. And obviously IDH1 and IDH2, they don't have per se a prognostic role in the current classification systems, but we do have specific IDH inhibitors. So those are very important for us to detect. So with that in mind, what is our current paradigm, treatment paradigm for newly diagnosed AML at MD Anderson? Essentially, the patient is assessed for pre-treatment characteristics, including age, comorbidities, performance status, and then previous exposure to chemotherapy or radiotherapy. And then this is where we come into play as hematopathologists. We do a comprehensive profiling of the AML, which includes, as I said, morphologic evaluation, immunophenotyping, cytogenetics, and then molecular analysis. And then based on the information that we obtain here, if the patient is eligible for intensive chemotherapy, and if they have core binding factor AML, they get intensive chemotherapy plus gemtuzumab. If they have a FLT3 mutation, they'll get intensive chemo plus a FLT3 inhibitor. And then the therapy-related acute myeloid leukemias or acute myeloid leukemia with myeloid dysplasia-related changes may get more intensive therapies like CPX351. And then again, the presence or absence of IDH2 mutations informs whether or not we can add a IDH inhibitor. And then for patients that are ineligible for intensive chemo, really the gold standard of therapy now includes HMA and venetoclax-based therapies, and then again, plus or minus FLT3 and IDH1 or 2 inhibitors. So what is our workflow like here at MD Anderson? So once the bone marrow biopsy is done, we get the aspirate in the lab. We're able to look at the aspirate the same day. Usually we have one pathologist on service that is reviewing every single new case. We do a blast count. We basically determine what additional tests may be necessary. We're still doing cytochemical stains because we find that, even though these are more traditional and older methods, they're fast and they're inexpensive, and they give us, some information that is needed for selection of therapy. Let's say an MPO positive, that it's acute myeloid leukemia, so you don't have to worry about B cell or T cell leukemias. And then we also get a preliminary scatter by flow cytometry using just CD45, CD34, and CD19, which gives us an assessment of, a rough estimate of the blast count, and also whether or not we're dealing with a B cell leukemia or not. Our cytogenetics lab does routine karyotyping in about 3 to 8 days, depending on what type of tumor we're dealing with. If it's a proliferative leukemia, like an AML with NPM1 or FLT3, you're going to get a karyotype back much faster. And if you're dealing with something more chronic, like MDS, obviously it's going to take a little bit longer. And then we have same-day FISH for PML-RARA to detect, detect the acute promyelocytic leukemias, and then core binding factor beta or inversion 16, translocation 821 or RUNX1, RUNX1T1, and BCR-ABL1. And our lab is able to turn these around in about 4 hours. So this is very, very important for us because these patients get put on specific trials, and it's very important for the treating clinicians to know this information within the first 24 hours. And then we do additional FISH as necessary. And then in the molecular diagnostic laboratory, we look for FLT3, which comes back in about 2 or 3 days. We have an 81 gene myeloid NGS panel that is resulted usually in about 3 to 5 days. And I'll show you that there are 10 genes in this panel that are usually resulted within 2 days. And then we look for recurrent translocations by PCR, and this is resulted out in 4 to 7 days. So this is our current NGS myeloid panel, and these are the 81 genes that are included in there. Within these genes, or among these genes, these 10 are, we report preliminary results on these 10 with a faster turnaround time of about 2 days. And the reason for that is that, they either have treatment implications like IDH1 or IDH2, or they're diagnostically important. And for some of our more challenging, let's say myeloproliferative neoplasms, it's helpful to know if the patient has a calreticulin, MIPL, or a JAK2 mutation. So that's diagnostically helpful. And so we've, designed this panel to be able to report these 10 genes out within 2 days. So let's look at an example. This is a new patient presenting with pancytopenia. They did a bone marrow exam to include an aspirate and a core biopsy. This is what we get on the first day. So as you can see, there are immature cells here, high NC ratio, a little bit irregular nuclear contour, prominent nucleoli, and these look like they could be myeloid or monocytic blasts. And then you have this dysplastic granulocyte here that's very hypogranular. And you also have cells like this that are very round, again, high NC ratio, very, very deeply basophilic cytoplasm. So it appears that this may be an erythroid blast. So we did flow cytometry on this. And if you look at the immunophenotyping, you can see that there are two distinct populations. So one population is CD117 positive, HLA-DR positive, and CD34 positive. Here, this is the same population. So these are aberrant myeloid blasts. And then in contrast, you have this population that is CD117 positive, but CD34 negative and HLA-DR negative. And these are consistent with the immature erythroid cells that we saw on the aspirate smears. When we get the bone marrow core biopsy the next day, you can appreciate that the normal hematopoietic elements are replaced by sheets of these immature cells. Your megakaryocytes, or what's left of them here, if you can see my arrow, this is a dysplastic megakaryocyte. It's very small, hypolobated. And then on higher magnification, you can confirm that these are blasts, very immature looking prominent nucleoli. We did a few immunohistochemical studies just because there was a question of erythroid differentiation in this case. And you can see that the CD34 positive cells are increased, but then the majority of the cells in the background are of erythroid lineage, as seen here by the E-cadherin stain. And then one of the things that we are now routinely doing is on our new acute leukemias, we're doing immunohistochemical staining for P53. Because it has very good correlation with the mutation status. And we're able to result this back to the treating physicians within about a day. And they're able to make treatment decisions on this stain because patients with TP53 mutations have now been shown to not respond as well to the treatments like ven-based treatments or HMAs. So these, this is an example of a P53 stain that is showing abnormal overexpression. And when we look at the karyotype and NGS studies, you can see that the karyotype is complex and it has a 17p deletion, as well as other abnormalities. And then this is a snapshot of the mutation screening or the NGS panel. That is showing that this AML has a RUNX1 mutation. It has several TET2 mutations. It does have a TP53 mutation in line with what we saw on the immunohistochemical staining, and then also a U2AF1 mutation. So with that information, and if we go back to the WHO classification for acute myeloid leukemias, this AML is subclassified as acute myeloid leukemia with myelodysplasia-related changes for several reasons. One is just by morphologic criteria, it makes AML MRC because it had 3 lineages that were dysplastic. And then also based on the chromosomal, it has a complex karyotype. So anything with a complex karyotype will be AML MRC. But then in addition to that complex karyotype, we saw that this patient had several very poor prognostic indicators, including a TP53 deletion. So based on these results, this patient was eligible for magrolimab, which is now one of the very desirable candidates that is being assessed in patients with TP53 mutations. It's an anti-CD47 antibody that affects the macrophage engulfing pathway, and it's used in combination with azacitidine. So this is what this patient was eligible for based on these results. So if you think about AML diagnosis, initial diagnosis is usually relatively easy when the patients are untreated. I think a lot of much of what we do in the treatment journey of the patient is during the surveillance and how we detect residual disease and how we monitor residual disease in these patients. And why is that important? If you look at the prognosis in patients with acute myeloid leukemia, we know that it's very variable. So some pre-treatment characteristics like age, karyotype, mutation profile, as we talked about, obviously are very important. But then response to treatment is also a very, very important indicator of how the patient is going to do in the course of the treatment. And the response to treatment is determined by several factors. So chemosensitivity of the acute myeloid leukemia is one factor. Achievement of complete remission, or what we call complete remission right now by morphologic criteria of having less than 5% blasts and recovery of peripheral blood counts. But But even if you achieve complete remission by morphologic counts, we know that the cure rate at best is about 50% in patients less than 60 years of age, and it's even worse in older individuals. So we know that morphologic assessment alone is not sufficient to predict outcome. What are the other factors that we can use to say, who is going to do better and who is going to do worse? Because this, this information is essential in choosing consolidation therapies for these patients. Is the patient going to go to allogeneic stem cell transplant, or are we going to put them on maintenance? And this is where measurable residual disease assessment comes into play for these patients. And we know now that it actually supersedes even sometimes pre-treatment characteristics. If in a patient that is able to achieve an MRD negative status, their prognosis is going to be far better than a patient that never achieves MRD negative status. But we know that MRD detection is not standardized across the field, even in the US. I think it may be a little bit more standardized in the European countries. But in the US, it certainly is not standardized. There's still debate on what is the optimal MRD assay. And I think this depends a lot on what type of leukemia you're dealing with and what pre-treatment characteristics the leukemia had. There's debate about the appropriate timing of MRD assessment and whether MRD assessment should or should not guide treatment decisions. So let's look at some of these methods that we're actually using. So, there's, we'll go, I guess, older to newer methods. So FISH, it doesn't have great sensitivity. The sensitivity is about 1%. It's only useful for acute myeloid leukemias that have either numeric cytogenetic abnormalities or have translocations. So it has low sensitivity, and it only is applicable in about 50% of AMLs because other AMLs don't have any cytogenetic abnormalities that you can detect with FISH. Flow still remains a very powerful tool. The sensitivity is high. For us, average sensitivity is somewhere around 10 to the -4, which is 1 in 10,000 cells. It's very sensitive. It's rapid. As I said, we're able to turn this around in about a day. It's relatively inexpensive, and we can use it in more than 90% of AMLs because the majority of AMLs have an aberrant immunophenotype that you can follow throughout the course of treatment. Now, the disadvantages of flow are that, AML is not like BALL. MRD detection in BALL is much easier because usually the phenotype stays the same in acute leukemias. But in AML, you can have phenotypic shifts and it becomes very difficult. The interpretation becomes very difficult. And it does require a lot of expertise. And again, as we said, the standardization across laboratories is very limited. And then RT-qPCR, again, it's very sensitive, but it's labor intensive. It's only applicable in about 50% of cases where you have a target that you can follow. So that leaves us with NGS. And NGS right now, the sensitivity, again, is variable without error correcting. And what is mostly available in routine clinical laboratories right now, the sensitivity is at best around 1%. The advantage is that you can look for multiple mutations at one time. Interpretation is relatively simple once you have a robust pipeline established. But then the results are confounded by clonal hematopoiesis, which we're going to talk about. It is still expensive, and it requires a lot of bioinformatics support. So with that in mind, and with the methods of MRD detection that we talked about, this is how we follow our patients at MD Anderson. Again, every patient that gets a follow-up or surveillance bone marrow gets a morphologic review of their bone marrow. We do flow cytometry to look for measurable residual disease. If the patient had, we do actually karyotype is done for all of bone marrows, but FISH is done selectively only to look for pre-treatment abnormalities that we were able to detect. And then the same is true with NGS. So we do follow up using the same panel, but the patient needs to have a pre-treatment mutation that is actually included in the panel for us to repeat the panel. So what are the clinical implications of AML MRD? The European Leukemia Net indicates that complete remission without measurable residual disease is an official AML response criterion for them. But again, this is not standardized across the US and in our current recommendations, although I think a lot of the academic centers are actually taking this information into account when making treatment decisions. And as we said, NGS and flow cytometry are complementary. There are leukemia-associated mutations and aberrant surface protein expression that we can look for to detect residual disease. So what do we look for when we're looking for residual AML by flow cytometry? We look for leukemia-associated immunophenotypes, and that is either when you have aberrant expression of antigens that are not normally present on myeloid cells, or what we call lineage infidelity. For example, if you see expression of B cell or T cell markers on what you know is a myeloid cell, that is lineage infidelity, and that's a leukemia-associated immunophenotype. We know that normal myeloid progenitors have very tightly regulated expression of antigens during their maturation. So when this becomes out of sync and you have asynchronous expression of antigens, that's also a form of abnormality that we can detect. And then the variation in the intensity of normal antigens, because we have, our flow cytometry assays are standardized, and we know that based on, a large number of normal bone marrows that we've looked at, we know what the normal intensity of these antigens is supposed to be. And so we look for variations from those normal levels. And a lot of the times, what we're limited by is that, at least at our center, the patients come to us and they've already been treated. So we don't really know what the original phenotype of the acute myeloid leukemia was. So the best we can do is to look for variations from normal. But this makes the case a little bit more difficult, because you can have atypical antigen expression, especially in the setting of regeneration. And this is more so encountered when the patients get growth factors or other stimulating therapies. So if you look at the prognostic impact of AML MRD by flow cytometry, it's really profound. Patients that achieve MRD negative status have a much lower cumulative risk of relapse and a much longer overall survival compared to those that don't. And if you look, let's talk about this again. And then also, if you look at MRD positive versus MRD negative, again, if you're only looking at flow cytometry, and you look at log reduction, again, that's a powerful indicator of whether the patient is, it's going to inform survival or not. And then another way we said of looking for measurable residual disease is NGS. So what do? We look for either persistent mutations that were present at initial diagnosis, or we look for new mutations that would denote clonal evolution. We know that the majority of AML are clonally heterogeneous, and the mutation landscape can change post-therapy. So it's not like, you don't have just one clone that you can follow throughout therapy. What we often see is that one mutation goes away and then other mutations persist, or new mutations develop at the time of relapse. So it's not a binary, just mutations present or mutations absent either. And the thing to know, and what really confounds measurable residual disease detection by NGS here, is the persistence of mutations that are associated with clonal hematopoiesis, namely the DTA or DNMT3A, TET2, and ASXL1 mutations. Because we know from experience now and from the literature that a lot of the times the driver mutations, for example, an NPM1 mutation, will disappear once you treat the patient, but the patients will have residual clonal hematopoiesis. So what does this mean in terms of prognosis? So for a mutation like NPM1 that is highly leukemogenic, and we know as a driver mutation, if you are able to achieve a 4 log reduction in the variant allelic frequency of NPM1, then your cumulative incidence of relapse is going to be significantly lower and the overall survival is going to be significantly higher. However, persistence of these DTA or the DNMT3A, TET2, and ASXL1 mutations have now been, it's been established that these really do not confer an increased risk of relapse. However, if you detect mutations other than these DTAs, obviously that is going to be prognostically important. So the best tool, I guess, is to combine NGS and flow cytometry. So the patients that are most likely to relapse are those that are going to have a combined positive NGS and flow cytometry. And then the ones that are least likely to relapse are the ones that achieve both flow cytometric and mutation clearance. And then the ones that have one or the other are somewhere in the middle. So what exactly is clonal hematopoiesis? It is the presence of clonal mutations in hematopoietic stem and progenitor cells in the absence of an overt hematologic disease. We know that the incidence increases with age. It's almost a universal feature of aging. And it's most commonly one or few mutations in genes that are recognized as early events in myeloid neoplasms. These include epigenetic modifiers like DNMT3A, TET2, ASXL1, or the IDH genes, splicing factors like SF3B1, SRSF2, and U2AF1, and then TP53 and JAK2 are also common genes that are implicated in clonal hematopoiesis. It also increases in incidence in patients with solid tumors, but this may be an association, basically by association of increasing age. And then it has potential association with prior exposure to oncologic therapy. So I invite you to read this. This is a review that was just published, I think, maybe a day or two ago by one of our wonderful leukemia fellows that I work with. And she's just done such a great job. I'm really proud of this paper, and I invite you to read it because there's just like a wealth of information here about clonal hematopoiesis. And I'd be happy to send you a copy if you'd like to email me and ask for one. I'm happy to send you a PDF. So again, as we said, clonal hematopoiesis, the incidence increases with age. And we know that the patients that have clonal hematopoiesis have an increased risk of developing hematologic malignancies. However, the risk is not universal. It's highly dependent on what type of mutation you have, the combination of mutations you have, the variant allelic frequency of the mutation, and also the other confounding factors such as smoking, prior exposure to therapy, and these specific factors also correlate with the type of mutation. For instance, ASXL1 clonal hematopoiesis is much more common in patients that are smokers compared to DNA damage response repair mutations are seen more commonly in patients with prior exposure to chemotherapy. So what does this mean for us? Let's look at an example of a case. This is a 61-year-old man that presents with newly diagnosed AML. This is the bone marrow aspirate smear at diagnosis, essentially all blasts. The bone marrow clot section shows replacement of normal hematopoietic elements by these immature cells. This is the baseline next generation sequencing panel. You have an ASXL1 mutation, an IDH2 mutation, TP53, and U2AF1. When you look at the post-induction bone marrow, I put the baseline here on top for you just to look at it as a comparison. These are the initial blasts. They were CD34 dimly positive. They're CD13 uniformly positive, and they have very bright expression of CD117 and decreased expression of HLA-DR. Now, if you look at the post-induction bone marrow, you can see that these myeloid progenitors, these are also the CD34 positive myeloid progenitors, they look very different compared to the baseline. Now they have much brighter CD38, which is closer to normal. The pattern of CD33 and CD13 is normal. This is what normal maturation looks like. And the CD117 now is less bright, or it's expressed at a normal level. However, we still have this distinct cluster of relatively brighter expressing CD123 cells. So what does this mean for us? Is this residual leukemia? Because if you look at the deviation from normal approach, this is not entirely normal. But here we have the advantage of comparing this to the baseline, and you can see that it's not the same as the baseline. So let's look at the mutations. This is how we visualize the sequence reads. This is using IGV, or the Integrated Genomic Viewer. So where you have the T's is actually where the mutation is, where a normal G has been replaced by a T. The baseline has a TP53 mutation. It has a deletion in ASXL1, and so does the post-induction bone marrow. So it still has these mutations. There's an insertion in U2AF1 that is also persistent in the post-induction bone marrow, but the IDH2 mutation that here was present in almost every read is now pretty much absent. So this is not the exact same clone. Is this residual clonal hematopoiesis, or is this a different clone of AML that is persistent in this patient? So to give you another example, this is a patient that had an acute myeloid leukemia arising from chronic myelomonocytic leukemia. Again, at baseline, everything is essentially blasts. These are monocytic blasts, a lot of promonocytes. Some look like more like your typical myeloid blasts. At baseline, the patient has an NPM1 mutation and then SRSF2, TET2, and Sybil mutations. When you look at the post-induction bone marrow, you have 12% blasts. There's still these residual immature looking cells, and you can see these in the clot. So if we go by the 5% cutoff to indicate morphologic remission, this patient still has not achieved that level, right? So do they have residual AML, or have they reverted back to their CMML? And if you look at the flow cytometry, this is the baseline here, and this is the post-induction. So here you have a population of monocytes that have, partially decreased expression of CD13. They have somewhat decreased expression of CD38, and they have increased expression of CD15 and partial loss of CD14. If you look at the post-induction bone marrow, here there's a really marked expansion of monocytes, which is of course abnormal, but we know that this patient has CMML. But if you look at the immunophenotype of the monocytes, here they have brighter CD13, they have brighter CD38, they have less expression of CD15, almost negative, and more expression of CD14. So the phenotype is much closer to normal monocytes compared with the baseline. So if you look at the mutation comparison, here, I'm sorry, the baseline and the post-induction is flipped. But basically the baseline here is on the bottom panel. You have residual TET2 and Sybil mutations. These both look the same. You have persistence of the SRSF2 mutation, but the NPM1 insertion that was present in the baseline bone marrow is now absent. So the NPM1 mutant clone has disappeared. So this is not residual AML, it's underlying CMML. But if you only went by morphologic count, you would probably be calling this residual acute myeloid leukemia just based on the morphologic, just based on the 12% blasts. And another way to show you this persistence of pre-leukemic cells, this is essentially days post-treatment. This is the variant allelic frequency on the y-axis of the mutations. And these on the right-hand side, the axis is the blast count. So as the blast count decreases by treatment, here in this patient, you can see that the NPM1 mutation disappears. It goes back to 0. But here, the DNMT3A and the TET2 mutation are persistent, and they actually have pretty high variant allelic frequency of about 40%. Similarly, in a patient that had NPM1, DNMT3A, ARID2, and FLT3 mutations at baseline, you can see that all mutations disappear. However, this DNMT3A mutation is persistent. So what does this mean for us in terms of flow cytometric detection of MRD? Because that's one of the cornerstones of MRD detection, at least for now in routine practice. How does it inform these phenotypic alterations? And to look at this, we recently, this paper was just published by us in British Journal of Hematology in February. And we looked at flow cytometric immunophenotypic alterations of persistent clonal hematopoiesis but we specifically looked at a cohort of NPM1 mutated leukemias. And the backstory behind this was that, we were doing these AML MRD panels, and we were noticing that in a subset of these patients that achieve NPM1 clearance. So we know that, the so-called leukemic clone has now disappeared. You still had some flow cytometric abnormalities in the CD34 positive myeloid precursors. Usually what we saw was a combination of one of these patterns. They're not necessarily all altered, but one or two is usually altered. And what we saw was increased CD117, 123, or 13, or decreased CD38 or HLA-DR expression. Importantly, you didn't have lineage infidelity. There was no aberrant expression of lymphoid antigens or complete loss or gain of other antigens. And it never resembled the original leukemia. So we knew that it wasn't the original leukemic clone. So we said, could this possibly represent residual clonal hematopoiesis? And I'm just going to refer to these as pre-leukemic cells for the sake of this study. So why did we choose NPM1 mutated AML to look at this? The reason is, first of all, NPM1 is very common. We know that about 30% of AMLs have NPM1 mutations. And it's usually associated with these clonal hematopoiesis mutations that persist during the course of therapy and once the patient achieves remission. The one good thing about NPM1 mutated leukemia is that it's strongly associated with a leukemic phenotype. So we know it's a driver mutation. And usually the flow cytometric immunophenotype is very characteristic, and it is easy to follow. So a lot of the NPM1 mutated AMLs, as you may know, have an APL-like immunophenotype, which is a CD34 negative, HLA-DR negative immunophenotype. So we thought this would be a good cohort to look at to be able to characterize these cells. So we had about 67 patients, and we looked at patients that had concurrent NGS and flow cytometry data, and that achieved NPM1 negative CR. So we know that their mutation status by just using NPM1 became normal. So these are the characteristics of the patient cohort. The majority of them had intermediate risk cytogenetics, as you would guess, because this is an NPM1 mutated cohort. And then they were treated with various treatment regimens, including intensive treatment regimens, or low intensity or HMA and ven-based regimens. So if you look at the mutational landscape at baseline, by definition, everyone had an NPM1 mutation, but then the other more common mutations were DNMT3A, FLT3, TET2, and IDH2. Again, not a surprise because that is the reported co-mutational patterns in NPM1 mutated leukemia in the literature as well. So then we looked at patients that achieved this NPM1 negative status post-CR, and then focused on patients that had residual clonal hematopoiesis, meaning they had residual mutations in the other genes other than NPM1. And here, the most common residual mutations were DNMT3A, TET2, IDH2, IDH1, ASXL1, and SRSF2. So this pre-leukemic immunophenotype that I described to you, we did not see this immunophenotype in any of the patients that completely cleared all of their mutations. So in the patients that completely cleared all of their mutations, they all reverted back to a completely normal immunophenotype. And this was statistically significant. Now, among the patients that had residual clonal hematopoiesis, about 50% of them had no immunophenotypic alterations, and another 49% had these myeloblasts with the pre-leukemic phenotype. And here's an example of what I'm talking about. So if you look at this patient's baseline leukemia, the blasts have CD117 positive, HLA-DR positive expression. They're CD34 negative, so the so-called APL, well, not APL-like because here it's HLA-DR positive, but anyhow, CD34 negative. And then CD123 positive, and CD13 and CD33 positive. Now, if you look at the post-treatment, this has now essentially reverted back to normal. These are normal CD34 positive cells with normal expressions of these antigens that we're looking at. Whereas if you look at this, the bottom panel is another patient that has an APL-like phenotype at baseline with 117 positive blasts, HLA-DR negative, CD34 negative. And if you look at the post-treatment, so we don't see these residual blasts. These are not there, but you still have some abnormal blasts. And why are they abnormal? Because if you compare these red cells to these red cells, so if these are normal, you can see that these have higher expression of CD117, right? They have higher levels of expression of CD123, and they have increased expression of CD13. So that's abnormal. So what did this mean in terms of some of the correlates with the other features of this patient cohort? So the patients that had residual clonal hematopoiesis with this pre-leukemic phenotype had a higher variant allelic frequency of their mutations. They had more frequent mutations, meaning more number of mutations compared to those that normalized their phenotype. And then the variant allelic frequency for DNMT3A mutations was significantly higher in the patients that had the pre-leukemic phenotype. And also when we looked at their follow-up bone marrows, the patients that had this pre-leukemic phenotype were the ones that had residual dysplasia in the background, morphologic dysplasia. In the patients that achieved a normal immunophenotype, we did not detect morphologic dysplasia. And this is important because it tells you that maybe there's a dysplastic clone in the background. And then one of the interesting things that we found is that IDH2 and SRSF2 mutations were exclusively seen in the patients that had residual clonal hematopoiesis. Now residual pre-leukemic cells. Now what's really important here is that although this phenotype is abnormal, it does not correlate with relapse. If you look at the percent survival or relapse-free survival, the patients with normalized flow cytometry and those with pre-leukemic cells did not have any statistically significant difference in their relapse-free survival. So it's very important not to overcall these and not to call this measurable residual disease if you're using the deviation from normal approach. So in summary, we know that this pre-leukemic phenotype can be identified in patients with treated NPM1 mutated AML. It's usually a small number of cells. I told you the characteristics. They're usually 13 positive, 33 positive, and show mild alterations of myeloid antigen expression. Very important not to overcall these as AML MRD, and they're usually associated with persistent clonal hematopoiesis with high mutation burden and morphologic dysplasia. Again, the long-term significance remains to be determined, but at least in the time frame that we looked at, it didn't have an impact on survival. Now, the limitations of this study were dissociation of genotype and phenotype, right? We were not looking at simultaneous expression of proteins in what we know was a mutated clone. The follow-up was short, and we're looking at inconsistent time points. So how can we optimize this? What are some of the opportunities moving forward? These are two very recently published papers. One is by our group at MD Anderson, and the other is by Ross Levine's group at Memorial Sloan Kettering, where basically they looked at the clonal landscape of acute myeloid leukemia. Now, the thing that I want to draw your attention to here is that in both of these papers, they were able to do studies using single cell sequencing where they looked at simultaneous expression of protein on cells that they were able to characterize at a single cell level genotypically. And now this becomes very important for us in terms of opportunities for MRD detection, because most likely how the field is going to move forward in the future is that we're going to combine these methods. So the flow cytometry and NGS methods are going to be combined, and we're going to look at single cell resolution. Now, the most prohibitive, thing right now for us to do this, first of all, is cost. And then these are very labor intensive, require a lot of bioinformatic expertise. So it's not quite ready for prime time, but I do think that it will in the future become the gold standard of MRD detection. And this is essentially what I just described. So, it's a summary of where I think the field is going to go. And obviously, doing these prospectively and in a trial setting will give us the opportunity to evaluate this with a systematic approach at specific and predetermined time points, and then with comparison of different treatment regimens, which will be a huge advantage, and it'll provide longer follow-up. So it'll be much more informative than what we are doing right now. And with that, I thank you for your attention, and I'll be happy to take any questions.
Thank you very much, Dr. Loghavi. Your presentation is really a state of art.
Thank you.
Yeah, I believe we're gonna open it up for the questions. Maybe any question?
I think there's some in the chat box. Let me stop sharing my screen so maybe I can see the chat box. Yeah. All right. So. All right. So it looks like Dr. Shadman has some.
Dr. Shadman, if you have any comments.
Actually, that's a very good question. So Dr. Shadman is asking this, I guess you're referring to the pre-leukemic immunophenotype, right? And how it correlates with treatment strategies. Actually, there was no association. So we saw this pre-leukemic phenotype in both patients that were treated with intensive therapies, as well as those that were treated with low dose, low intensity therapies, including HMA and VEN. So it really didn't, it wasn't impacted by the treatment mode. And then any chance to target the mutated clones. So are you referring to post-therapy or before the patient develops leukemia? Where are we? Which one of these are you referring to, Dr.
Just to clarify, the question was from Dr. Akbarpour, sounds like.
Oh, sorry, yeah, I guess.
So if he can maybe clarify.
Oh, yeah, I'm sorry. I don't know why I thought it was.
I just want to make sure he knows that there's a follow-up question from you. So.
Sure. Yeah, thank you. I saw that. So again, to target these mutated clones, I think we're still not there yet. So, what we're basically able to do right now, I think the lowest hanging fruit is not actually mitigating leukemia risk reduction. There's a lot of literature and a lot of research being done on lowering the risk of cardiovascular diseases in patients with clonal hematopoiesis. But I think in terms of leukemia risk reduction, where it's most informative for us right now is possibly selecting therapy modalities in patients with solid tumors. Because one of the things that I didn't discuss here for the sake of time is that we know that in patients with clonal hematopoiesis that receive chemotherapy for solid tumors, their risk of developing subsequent therapy-related myeloid neoplasms are far higher than those without clonal hematopoiesis. So I think that's perhaps one setting where there can be some, basically treatment planning for these patients where you select, and of course, it's not like we have an unlimited option of treatments. But I think, at least the oncologist can be informed that this patient has a higher risk of developing a subsequent therapy-related myeloid neoplasms, and they can make decisions based on this information. But right now, they are not targeting these mutations, at least in the routine clinical setting.
Here's another question. Would you please say what would you do if you have a 180-degree discrepancy between morphology and IC?
I think that's really, it really depends on the specific case you're talking about. I think it highly depends on whether or not your sample is adequate. Let's say, I don't know what the specific question is, but let's say if you're trying to determine blast count and you have a very limited, hypocellular aspirate sample that doesn't have a lot of blasts, but then you have a core biopsy and you do a CD34 IHC and it's loaded with blasts, of course, I'm going to go with with whatever sample is more informative and what makes more sense to me. But I think it highly depends on the setting, on the specific question. What IHC are we talking about? What morphology are we talking about? I hope that helps.
Okay. And I personally have a question about AML and 4 flow cytometrically. Professor Sao Wang, that is working your center, always said that we have to follow the blast according to CD34. Of course, monoblasts and promonocytes do not have CD34, but in MRD flow cytometrically, we have to follow MRD by CD34. Is it right now a correct comment or not?
Yes and no. So, the monocytic leukemias are nightmare. They're the hardest to follow by flow cytometry, as you said, because first of all, usually monocytic blasts are not CD34 positive, but our AML MRD panel does specifically gate on monocytes. So we do look for monocytic abnormalities. However, what is really helpful is usually when the leukemic clone disappears, your normal CD34 positive cells reemerge. So if you see a good normal CD34 positive cells, usually the monocytes are going to look normal too. And I think that's what's helpful. But a lot of the times the aberrancies on the actual monocytes can be very subtle. And if you don't have a normal CD34 positive population, you should be very, very suspicious of residual leukemia, because usually, again, in the setting of normal regeneration, you're going to see the normal CD34 positive cells come back.
And these are actually regenerating myeloid series, not the plastic.
Correct. Regenerating normal CD34 positive myeloid blasts.
Yeah, thank you. Another question.
Dr. Biklari, continue a question about plasma cell leukemia and IHC over AML. Continue other 180 degree continue کرده بین morphology plasma cell leukemia and IHC over AML.
And what is our strategy about the discrepancy between morphology of plasma cell leukemia and IHC in overt AML?
About plasma cell leukemia?
Yeah, it's a kind of questions.
Sorry, is that in the chat? Can I read the question?
Maybe.
Dr.
Big Larry had a question, but I mean, we had a case with morphology of plasma cell leukemia and IHC of AML. There might be a discrepancy between morphology and IHC.
Right. I mean, I think, blasts can have any type of morphology. If they're marking like AML, I would certainly, go with the IHC, because I don't think, you can have plasmacytoid looking blasts that can be myeloid. So in that case, I think the IHC is probably more informative. But again, I don't want to make this comment in a vacuum. I'd really like to see the actual case. But I think in terms of lineage determination, I would trust the IHC over morphology. And then I think one person has a question of AML with recurrent genetic abnormalities, which method to follow for MRD. It depends on what recurrent genetic abnormality you're talking about. But in terms of, I'm assuming that you're referring to 15, 17, APL with PML-RARA, core binding factor leukemias. So for APL, we don't even bother doing flow. We just do PCR in FISH, and that's what we're using right now for MRD detection. For inversion 16 and 821, we are still doing both. So we do flow and we do PCR. But obviously PCR is the gold standard because it's objective and more sensitive.
Thank you very much. And about the next generation sequences, when we have, for example, those genes that are that favors favorable prognosis, and we have also some genes that have bad prognosis, bad prognostic factors. What would you do if we have next generation results with these two different prognostic factors?
Right. So, you know, in the majority of the cases, usually the gene that is associated with a bad prognosis is the one that informs essentially the outcome and dictates the outcome. So, you know, a good example would be having an NPM1 mutation with a high mutation burden FLT3-ITD mutation. So NPM1 is good, but if you have a FLT3-ITD, that's going to trump it, and that's going to push you into the intermediate risk category. Or, you know, if you have, I don't know, for instance, I mean, the only really good mutations are NPM1 and CEBPA, right? Other ones are either bad or they have really no prognostic impact. But essentially, if you have a bad mutation with either of those, that bad mutation is going to dictate the course.
Yeah, thank you. And there is another question. It says, do you have any experience using agents like, what's that? Like sorafenib in extramedullary relapse, for example, in tissue biopsy?
So, you know, again, with the disclaimer that I'm not an oncologist, I'm a pathologist, so I don't directly choose therapy for anything. But yeah, I mean, I think if you have a FLT3 mutation, so right now, but you're saying positive for KIT by IHC. So KIT by IHC really does not mean, it's just CD117, right? It's just a myeloid marker. It's not, it doesn't correlate with any mutation or anything. But I think if you have something that has a FLT3 mutation, then using a FLT3 inhibitor is probably reasonable. I don't know which FLT3 inhibitor they would choose, but I think in that setting, whether it be bone marrow based or extramedullary, it would make sense.
Another question, can we use FLT3-ITD mutation for MRD?
Yes, yes. And in fact, that is one of the things that we do. You have to be careful about the sensitivity of the assay you're using. So, you know, right now, like In Vivo Scribe in the US has an assay that is 10 to the minus 5 sensitive. So 1 in 100,000 cells it can pick up. Basically one mutant allele in 100,000 cells. So it's a very robust assay, but then there are some assays, you know, like capillary electrophoresis is going to have a sensitivity of around 1%. So in that case, the cutoff value of FLT3. Oh, and anything you detect is abnormal, right? It just depends on the lower limit of detection of your assay. So again, as I said, some assays are very robust. The lower limit of detection is going to be 10 to the minus 5, whereas for others, it's going to be 10 to the minus 2. So if you're looking at an assay that has a 10 to the minus 2 lower limit of detection, obviously flow cytometry is going to be much more powerful. But if you're looking at 10 to the minus 5, then your FLT3 assay is going to be more sensitive.
Another question, hi, in Iran, we don't have NGS method. So the best way to check MRD, maybe flow cytometry.
Flow cytometry. Yeah. But I think, you know, flow cytometry is still very, and maybe because, you know, it's, I'm a flow person. Obviously, you know, I do a lot of molecular too, but I still believe that flow cytometry is extremely powerful and extremely informative. It's just that it's very difficult to interpret. But if you have the expertise and if you have the standardized instruments and methods to do it, then it's very, very powerful.
Oh, yeah. So And our question is,
No, 3 to 4 channel flow cytometry is enough. No, so right now we are looking at, I mean, so it depends. If you're looking for very small populations and subtle changes and you're trying to characterize with, you know, a large panel of antibodies, then no, 3 to 4 channel is not enough. Right now, what we're using is either 8 color or 10 color flow cytometry for AML MRD.
I think 3 or 4 color flow cytometry is you have to lose your money for detecting minimal residual disease, because you have to use many antibodies in flow cytometry to reach the blast clone. Yeah. Another question you said about 81 gene panel in NGS. What about yet unrevealed genes?
Right. So these are not discovery panels, right? These are essentially clinical assays that are being done based on what is in the literature. So the majority of I would say that the majority of mutations in AML, you know, there's been a lot of whole genome sequencing studies that have been done in large subsets of AMLs. So I'm not worried about us not detecting, you know, there may be very rare mutations that we're missing, but I think the majority of standard NGS panels in the academic centers right now in the US cover a large subset of genes that are implicated in acute myeloid leukemia.
So any other questions?
Yeah, so they're saying that the antibodies are expensive. Actually, flow is expensive here too. So I think, you know, I don't know what the cost is in Iran, but I think here, I think getting an MRD panel is somewhere around a couple $1,000s. So it's not cheap. It's not cheap here either. It's unfortunately, you know, the technical aspects are expensive, obviously institutional overheads and everything. So it's very expensive here too. But if you compare that to a CT scan, it's still cheaper. So
yeah. Another question, does CD117 expression by flow cytometry in AML indicate whether KIT is mutated or not?
No, it does not at all. So normal normal myeloid progenitors are CD117 positive. It does not correlate with mutation status at all.
Yeah. In Iran, MRD detection by flow cytometry costs about more than 2.5 million TUMS, and that's about maybe 1,000, maybe more dollars in.
No, $1,000 is I think 25 million. No.
Yeah.
Yeah. You know, I think so. So does every new diagnosis of AML in Iran get flow cytometry, and you know how are new leukemias worked up there right now?
Yeah, it depends on the centers. For example, we in Shariati Hospital, we have flow cytometry, but we cannot do MRD detection by flow cytometry because we have only 5-color flow cytometry. Yeah. And maybe in some centers in Shiraz University, they have 8 or 10-color flow cytometry, and they can detect, but it is not usual to do it in Iran.
I mean, it's not done, you know, you would think, I mean, even in the US, a lot of even academic centers don't do AML MRD. Like I said, it's not very routine. You have to go to the larger academic centers that have a large leukemia population, or, you know, run a lot of clinical trials like ours.
Yeah. Is there any question? Any other question? Okay. That's going to conclude our section for today. Yeah.
All right. Thank you so much for having me. This was a lot of fun. I wish I could have done this in person in Iran. I miss Iran a lot. So
yeah, of course. Thank you very much. Thank you so much, Dr. Law, for your nice presentation. It was really state of art. And thanks everybody who stayed with us. And we are looking forward to seeing you back here in the following lecture.
Absolutely. Thank you so much to everyone who participated. And thank you again for having me. Many thanks to Dr. Shadman, Dr. Yaghmaei, and yourself.
Thank you very much.
Bye.
Bye.